So my aim is in the next 30 minutes, 35 minutes is to give you an overview. This is a very passionate topic for me. I've been working both in UK and abroad on this particular highly sensitive and difficult topic actually for about 15 years now. And um, I would encourage anyone who wants to have a little bit of work um, to contact me separately after you've gone through what we're going to cover slightly, just to give you a flavor of the definitions, the terms, what's happening around the world, what the mechanisms. I mean, yeah, we deal with the arrests, but we are not getting any better. We're still actually where we were. In fact, we might be getting worse in terms of out of hospital arrests. There's loads of vagaries and stuff around this whole term called cardiac arrest, cardiac death, or sudden cardiac arrest, sudden cardiac death, etc., etc., and also ways forward as to what's happening and how we can screen, how we can risk stratify, and some initiatives which there's a lot of work happening, and every single day, if not, you know, every single week, if not every single day, you would learn something if you have interest in this particular field. So, SCA versus SCD, I think they're interchangeable terms. There has to be sudden cessation of cardiac activity. Research has shown that most of them happen in people with structural disease. You use the word sudden cardiac arrest only if there is ROSC via intervention or spontaneous. Death, if there is death, both fatal and non-cardiac fatal arrest. The outcome depends on different factors, and majority of individuals with this kind of problem will be unconscious within seconds to minutes. Most of them may not have any premonitory symptoms as classically historically defined, but if they have any symptoms, they're generally non-specific, just a feeling as described, in different terms. However, things have changed over the last decade or so. But we say that for it to be called a sudden cardiac death, it has to be within an hour of symptoms in somebody who was last seen when and alive 24 hours ago at least. Now, we have moved beyond trying to redefine this as sudden arrhythmic death syndrome, sudden unexplained death, unexplained sudden cardiac death, etc., etc. Now, that's only applies if you can't find a cause on post-mortem examination. And also, about 50% will have at least some form of symptom. About a quarter of STEMI would present as VT, VF, and half of them would die, would not reach the hospital. VF is the usual cause, and survival to hospital discharge maybe less than 10% for out of hospital, up to 50% approaching now in the best units for in-hospital arrests, especially if they're shockable rhythms. There's a wide variety of global variation and data collection issues. The VF seems to be on decline with prompt treatment strategies, especially in the Western world. But there's so much to do around the world, and COVID itself completely changed the landscape, at least for 4 or 5 years, which is now baselining in the last couple of years' time. It might not seem as sudden, actually, because there was a paper in 2019 which actually went through quite systematically, witnessed arrest, that there were symptoms of, as listed above in the slide. And in our own experience, we've seen that, yeah, not all arrests are completely asymptomatic, and there will be at least some form of symptom, something not right, something unwell, discomfort, just a general feeling of impending doom, so on and so forth. In fact, a couple of weeks ago, I had a patient who was just feeling unwell for 3-4 hours at night and arrested about 3 o'clock in the morning. So In trying to understand this, we need to just go through this slightly in as simplistic way as possible. So there was a lot of work done before 2020 around, how can we risk stratify and put them in different contexts. So someone who could be elderly, for example, if you look at the hypothesis of a general model versus a detailed model, you would see that, there's various factors which kick in on top of the general model, whereas prior event, structural heart disease, non-cardiac problems, and family history as some of the key parameters. And then you just throw in comorbidities, advanced age or age, which is the single most important factor, other things which are listed here, and then you can have an interplay of things in terms of trying to understand the risk axis of sudden cardiac death, arrest, whatever you may want to call this as. And in trying to broadly understand, at the top, you have the SCD risk so there are three triangles. The first one is an incidence rate. So you could see that the risk is highest in people with high risk cohorts for the first triangle and the lowest in the general population. This triangle inverts in the center of the three, where the annual number of events, if you had to go by, would be maximum in the general population, simply because of statistics, and the acceptable diagnostic complexity of the tests you use would be much less useful if you had to apply to general population compared to high risk cohorts. So that's a very good way of understanding this. This was a really fantastic paper to try and give you the perspective how complicated this whole field is, and you may or may not win, but keep up with screening as much as possible. Incidence now, very weird. There's so varied incidence in general around the world, and these are the countries which maintain a register or some sort of data, but most of the countries in the world have no data collection or a register or some form of logging this as for clinical coding purposes. So this is again quite varied. In general, the younger the patient, the less the incidence, the higher age, especially above 75, the incidence is much, much higher, and that's a well-recognized fact. Males tend to have more events, except for very advanced ages and very young ages. Now, we are not dealing with pediatric arrests or SCA events in this particular session, which is outside the remit. But this was a paper which just showed that the single most denominator was age, and age. Above 65 are the ones where you'd find this incidence as highest. Now, let's come to the UK statistics from the most up-to-date ones, which is from Rhesus UK. So we had about 54 per 100,000. And mind you, 80% occur indoors in homes. So imagine how difficult it is a problem. 50% are witnessed, the rest are not. Bystander CPR is going up. It's now 6 to 7 out of 10. 60 to 65% would be males, and about more than 2/3 would be due to a cardiac cause. The shockable rhythm would only be found in about a quarter. And quite difficult fact is that as of 2024-25, the public access defib use is still about less than 1 in 10. So much of inequalities. This is UK now, which drives up the incidence and brings down the incidence of bystander attention and access to AEDs. There's a lot of postcode lottery, and the mean ambulance times are not too different, 7 minutes, 9 minutes average across England, Northern Ireland, Wales. ROSC only in about 27% of attempted resus out of hospital, and where they made it, only 9% survived to hospital discharge. Out of them, only 9.5% survived at 30 days. The Epstein group is a group where was basically a comparator group where there was a presumed cardiac cause, witnessed arrest, and shockable rhythm. That's always used as a comparator, which has a better survival rate. And all the statistics, the more you see from Resus UK website, you'd see that England has better stats than Scotland, has better stats than Wales, and some of the worst stats are from Northern Ireland, and you won't be surprised for obvious reasons, which we shouldn't be going into detail in this session. In hospital arrest, again, it hasn't really changed compared to the data from 2021, 22, 23. This is 23, 24, 25 data. Average age is generally older, and about 85% occur on medical wards. The interesting thing is that about up to a quarter occur on presentation to hospital, actually. And a half of them would happen in hospital, and a minority are in critical care or coronary care. So it's quite interesting how this data pans out. The initial rhythm is non-shockable, or PEA, as you would know, as per your research training and all the details. And ROSC only in about half of them, only if you have a proper research team in the hospital. And about a quarter survive to hospital discharge, with majority having a favorable neurological outcome if they survive to discharge. So that's stats as they stand, and you can always visit the Resus UK website and get more insights into it as the guidance. Some of the guidance has changed in 2025 about BLS, a little bit some ALS, and there's lots of other things have come in. Now, cause-wise, we know, you know, that about 2/3 are due to coronary heart disease, mainly coronary occlusion, arrhythmias, etc. Then comes cardiomyopathies, which is muscle disease. And then comes the channelopathies or inherited arrhythmias, some valvular heart disease. So minority then leaves to the other things, which could be pulmonary embolism, etc., etc. Heart failure with reduced ejection fraction is a specific denominator and factor for sudden cardiac arrest, where the muscle is dysfunctional and it can throw reentrant fatal arrhythmias. So one has to really counsel and that's why there's so much emphasis on discussions that this is a risk, and wherever possible, one should aim for offering primary prevention ICD or secondary prevention if necessary, if applicable, actually. Now, this is a busy slide, but I'd just like you to draw your attention to the complex way of how electrically, arterially, inflammation-wise, neurology-wise, genetic-wise, got so many different mechanisms of how things can go wrong in terms of causing a fatal or near fatal arrhythmia. So I wouldn't go into detail, but some of the most common mechanisms include reentrant arrhythmias, mainly triggered by scars, triggered by abnormal repolarizations, channelopathies, ion channel abnormalities. We're only sitting on the tip of the iceberg currently, and catecholamine surges. Now we have a term called catecholaminergic VT and VF, where somebody just has a surge and they're going to VF. I had a case like that, which went actually to coroner's court. And myocardial ischemia, etc., etc. Inflammation. On the left side, you have a comprehensive list, causes of sudden cardiac arrest, death, whatever you may want to call it as. It may not be fully comprehensive, but it just summarizes what you have with structural disease, with no structural disease, and other causes, and with coronary disease. That's again a graphic way of trying to explain to you how complicated and interrelated the factors can be in causing sudden cardiac death, arrest, etc. The Research Council UK in 2025 emphasizes that before you assess for breathing, you must call for help. So that has been a change. And on the in hospital, again, it's about call, compress, and collect. You would be aware of all that, but I'll leave you to go through them on the Research Council website and download. I can share them in the chat box, these documents, but they're freely available to download. So there's been slight modification and changes, mainly to aim early CPR, early chest compression, as early as possible, and not worry for rescue breaths, and change the compressor at every rhythm check. So that's some of the stuff. Adrenaline still remains after the third shock, and defibrillation, prompt defibrillation, chest compression, call, compress, collect, the equipment, blah, blah, blah. So that still remains the core. This is just to mention that things are updated on the Research Council website. Now, the circuit, you need to just remember this word, is the first of its kind national UK-wide public access AED registry. And you'd be very quite interested to know that every member of the public can just click a website and find where there is a nearest defibrillator. And that is a registered one. And as of June last year, more than 100,000 AEDs were registered, with more than 200,000 deployments logged, but there were no details available to at the point where one could say that whether the AEDs reached the actual scene of out-of-hospital arrest or were used properly. We don't have that data as yet, but the circuit registry should provide more data going forwards. But this is a fantastic initiative, one of its kind. So Defib Finder is a website you can go on and find the nearest defibrillator where you are actually. Arrest trial, I must mention, was a landmark study presented at the European Society of Cardiology, which I was part of in 2023. It was published the same night because it had such wide-ranging implications. The key learning from that was that if you have cardiac arrest, it was run by London Ambulance Service. There was no medical personnel involved. It was completely run by paramedics. And it was a randomized study. You can imagine how difficult it might be to conduct a randomized study for cardiac arrests. And it kind of proved that if you have cardiac arrest and there's no ST elevation, no need to transfer to a high-tech center, or in our case, LGI. Just take them to the nearest emergency department where there are resuscitation facilities or advanced facilities, intensive care, etc. Full stop. There was no difference if the patient were taken to a heart attack center or a community A&E department. No difference whatsoever unless there was ST elevation myocardial infarction. So it had such a wide impact in the meeting and the Congress that the European Heart Journal decided to publish it the same night, because this has changed the practice around the world, that you don't waste time. You just take the patient as soon as they're ROSC. If they've survived, just take them straight away to the nearest hospital. Few things we want you guys to know, that there is phenotyping. If someone survives cardiac arrest, you want to know what their prognosis is. And coming from all these arrest studies and in the studies leading up to it, we have now 2 scores which can be done relatively easily, called Sky5 and Miracle 2, which kind of phenotype patients as to non-shocked, hemodynamically shocked, hypoperfusion basically, but nothing else going on, and hemometabolic shock. And you can see how their prognosis differs in terms of, and that's how you'd have conversations with families and their loved ones if they are surviving and um, and decisions about stopping life-sustaining treatments if they're required with an MDT approach. So the hemometabolic shock is the one where you've got everything going off, and they have the worst prognosis. So this is the phenotyping of survivors. Linked to that is neuroprognostication, which is now mandated at 72 hours in survivors of cardiac arrest. And that's generally done by a trained team who are really good at putting things together. And depending on what the prognostic assessment is, taking into account everything in particular, you then approach the family, etc., and update them on a regular basis. And from that point of view, you can easily make decisions in a more objective way and justify them in the right way. So it has some timelines to it, and it's usually recommended. Now it's part of the new recommendation, new guidelines from 2025, that we must do it at 72 hours after ROSC. So it involves a few tests, including a full neuro examination, EEG, some spontaneous electric potentials, a CT head, MRI if possible, so on and so forth, based on patient's condition. So, having covered that, I think, how would you approach this in your day-to-day routine if you're just walking around and somebody says, I'm scared about, this whole business? I think the right way is to just go very conventional, take a good history, including family history, do a 12-lead ECG, and then think about anything else. So those are the still important and key pillars to this. Imaging certainly is key. We know that you can diagnose conditions like hypertrophic cardiomyopathy. In this case, you can see quite an asymmetrically thickened interventricular septum in comparison with the posterior wall of the left ventricle, which is called asymmetric septal hypertrophy with left ventricular outflow tract obstruction. And this is classic hypertrophic obstructive cardiomyopathy. On the other hand, you have a cardiac MRI scan where there are abnormal signal intensities in the right ventricle, which indicate that this area of muscle is electrically unstable, what we call as an arrhythmogenic right ventricular dysplasia, cardiomyopathy, etc., which can lead to abnormal electrical potentials and reentrant arrhythmias, especially VT, VF, risk of sudden death. And if you foresee all that, you then offer primary prevention treatment like an ICD to treat. In patient ischemic heart disease, CT scans really change the whole dynamics of assessment of these patients. And this is a good example where a simple 5-minute test can give you enough information about lots of structures, including the arteries, the aorta, the pulmonary arteries, the muscle, etc., etc. So in this case, you have a critical proximal LAD stenosis, and if that gets thrombosed, the patient may have maybe in that 25% category where they have a massive ST elevation MI, but electrically heavily unstable and can throw off a VTVF and may not survive their journey to hospital. Cardiac MRI, I've just explained. It assesses lots of things. It's one of the best tests where you can assess structure, function, ischemia, scarring, all sorts of things. Infiltration, especially if they can lead to muscle dysfunction and arrhythmias, and also abnormal coronary arteries and stuff like that, which can also be seen on CT scan. This is a cardiac MRI in a patient with dysfunction of the ventricle and some abnormal signal intensities. So these are just for diagram for you to understand that you use a combination of technologies as applicable. For those who survive and are suitable, they would not leave the hospital without having a secondary prevention implantable cardiac defibrillator, and a very minority of them who are not suitable to undergo transvenous systems like 2 leads, one in atrium, one in ventricle, with a pulse generator. These are the shocking coils. That's the lead which is going into the ventricle. That's the lead which is going into the right atrium. It's a dual chamber intra cardiac defibrillator. And there's a minority which would have subcutaneous implantation as a new technique, where there's radiotherapy, there's not enough skin, there's lots of other issues, young patients and stuff like that, where you can put this subcutaneously, and that's a relatively new technique compared with conventional process using the wires. Managing the risk generally involves assessing relatives of people with suggestive symptoms, mainly dizziness, collapse, palpitations, stuff like that. And initial aim to avoid competitive sports or strenuous exertion, recreational sports, continued observation at all times, and then eventually intervening if necessary. That's just a summary, but the focus is history, including family tree, a 12-lead ECG, and then going on to imaging, echo and CT scan, MRI. If necessary, you go for invasive assessment or prognostic assessments like a treadmill test. And then you decide what you want to do, actually. And if there's acute coronary syndrome, then you manage it on that line. And the overall context is within compliance with the evidence-based treatments. And whatever we've achieved so far in terms of success, whether it's in hospital, there hasn't been much success in out-of-hospital arrests, but in the developed side of countries, can be attributed to these interventions in a structured manner. Now, this was published in December, pre-participation athletics screening. It's now a hot debate, hot topic. People are exercising a lot, and not all of them are kind of being assessed the way they need to be, or so anyone who may be deemed high risk or who thinks they're high risk, there's a little bit of family history, there's a little bit of thing. It's been proven now that a simple 12-lead ECG can pick up to 94% of underlying cardiovascular disease. Simple. So beyond that, the history just provides about 20%, 25%. Examination doesn't really give you much information. But if you do serial screening, you can get more information if you miss something on initial evaluation. And there are updated international ECG criteria I'm going to show you, which have been agreed now. And this is called pre-participation screening. You can go for family interventions, inherited cardiac conditions clinics, so on and so forth, if need be. And this is what's been agreed. This paper was published in British Journal of Cardiology last month. And you can see that you'd be a bit worried if somebody was exercising a lot and there were T inversions, ST depressions, Q waves, bundle branch block, broad QRS, stuff like that. It's all self-explanatory. Whereas a lot of people with, bradycardia, junctional rhythm at night, first degree AV block, morbid type 1, they're all physiological findings and expected findings in athletes and young people. Early repolarization or ST elevation, which a lot of A&E doctors would have seen, being seen as query pericarditis, etc. But they're all normal variants, incomplete right bundle branch block, and slightly increased voltages, where these says voltage criteria, LVH, RVH, etc. So these are all within normal limits. There are some borderline findings which you need to put in context, and then it's been agreed that if you've got any of these, you do further evaluation. 2 or more, you do evaluation. In isolation, you don't need to. Just reassure, monitor if you have to. Now, we've got 5 minutes, or maybe 7 to 8 minutes. We will break at 3:20 precisely. What do you think this ECG shows? Please feel free to comment in the chat box. So this is a pre-participation screening in somebody who wants to, who's training for a half marathon in 2-3 months' time. Sorry. Anyone? Speak out if you want to, please. Okay, so Brugada pattern, Brugada. What made you think it's Brugada? Can you speak out, Daniel, Liam?
It was mainly the ST elevation, well, in that kind of shape, with the T wave inversion predominantly in the anterior chest leads.
What shape you said? What you want to be a bit more specific for your colleagues? Thank you.
I think is it saddle or something that they say?
Yeah,
Is that
excellent. Yeah, perfect. Yeah. Yeah, so this is a very classic ECG, which you don't see very often, but when you see it, you get worried, and you can't just say that, oh, it's RSR pattern or incomplete right bundle branch block pattern, because it's got saddle-shaped and curved ST elevation along with T inversion in the right precordial leads V1, V2. It has a very high sensitivity. It may not be there next day, and you may have to provoke it, but the moment you see it, you start to worry about them having syncopal episodes, etc. So they need to then go and have further assessments and then have treatments as indicated. So well done on that. Anyone who thought this is a classic Brugada ECG, which is a channelopathy. It's a sodium channelopathy where there's a sodium channel abnormality which predisposes to cardiac arrhythmias, often ventricular tachycardia and fibrillation. There's quite a few, but this one is one of the classic ones. I think we've covered this in a way where you need to think about preventive measures, both from an out of hospital and in hospital perspective. And the better the research team, the better outcomes would be. And the better awareness outside, the better the outcomes might be. But still, I don't think we're getting there. It's going to be, there's so many roadblocks. Who should have genetic testing? I think people who have family history. And if there is one mutation identified in one individual, then it's generally offered to all the members at risk. We have there's a list of genetic abnormalities here. You don't need to remember them, but just bear in mind that there are quite a few conditions and we have now a fully functional and well-running, very comprehensive inherited cardiac conditions clinic, which is linked with the clinical genetics in Leeds as a regional service. We have an MDT every week where you can discuss a case which you're worried about, ECG, imaging, history, anything, and then you can discuss and then put that patient through that pathway, and they're seen that they have an assessment, and if necessary, they offer genetic testing and further treatments if necessary, or monitoring. We have also these tools to hand. You can insert this now, not implant it, as a loop recorder, and that can stay in for up to 3 years approximately in the chest wall. And if there's an event, you can interrogate what actually was the correlation in terms of rhythm or symptom rhythm correlation. We have picked up a few things, not necessarily VTVF, but mainly bradyarrhythmias requiring permanent pacemaker. Wearable technologies may allow you up to a month worth of detection, and we have a few now. It's expanding. but the cabled technology is going away generally, and this is replacing what used to be a conventional 7-day event recorder, etc. Mobile ECG is quite easy now. It's available on smartwatches and also some other devices which give you high quality tracings. And the current policy in UK is pretty, I'm not personally quite happy having watched it right from beginning and having mentored some of the people who might be involved. Um, I think it aims to identify people at risk in general, yes. But overall, it's underestimating the incidence of young cardiac, um, young patient or young population at risk for SCD. And as of today, it's not fit for purpose. It should expand as much as possible. And that's why there's been some guidance change in the Research Council that we should be rolling out CPR training to the lowest age groups as young as 4 to 6 year old in the school. So you can see the changing mindsets, that how much emphasis we are putting on this nationally. Even then, our survival rates still remain as what they were. That's just from the Cardiac Risk in Young website. You can just go on this and see they do clinics in the community. And if you're worried about someone, you can ask them to attend. They have an ECG, and if necessary, they are referred to the local hospital for assessments, which we would then carry out, starting with an ECG and echocardiogram to start with. This is just for you to think that, okay, well, we have everything to our hand here, but there's rest of the world which has literally nothing. And there are multiple gyms where there's no regulation, no AEDs. So much of valvular heart disease, malnutrition, so much of problems all around without diagnosis, poorly managed risk factors. And so we expect that the incidence on the other side of the world would go up by 2030. That's the prediction as of now. And unmet needs in underdeveloped and deprived areas outside UK or outside the West. I think Lancet Commission in 2023 set out to try and address all this on a global basis, involving different countries, trying to raise awareness, trying to call for more AEDs, public awareness campaigns, local models of care where you could have AEDs every few. We've done some work and we are involved actively at this point in time as I speak. Focused meetings, screening of high-risk individuals, having clinicians with special interests, actually. And of course, one-stop clinics as we have here, and implants at lower rates because, these ICDs don't come at cheap costs. And having registers, having clinical coding. Otherwise, you wouldn't really know what the incidence and prevalence is. So, and support mechanisms for survivors, families, risk groups. There's a lot of work to do on this aspect. So this is my last slide. And so remember, chest compression, chest compression, chest compression, rescue breaths only if trained for, and then proper screening, ECG and imaging, and pre-participation screening can help you with a physical examination, history, but mainly a 12-lead ECG to start with, along with everything else, and awareness in general. Thank you for your listening.